Hello and welcome, everyone. My name is Kristen Talbot, and I'm the program manager for MAVEN Project. Thank you all for joining us today, and our friends at Mariposa Community Health Center for hosting today's session, Dermatology Basics Common Dermatoses with Dr. Wendy Huber. Dr. Huber is the former chief of dermatology at Kaiser Permanente South Sacramento Medical Center in California. She retired after more than 3 decades in practice, and in 2000, she was awarded the TPMG Exceptional Contribution Award in recognition of her efforts and continued to serve as a latex allergy program-wide resource until retirement. And we're very lucky to have her as a MAVEN Project volunteer. So Dr. Huber, when you're ready, please bring up your slide deck and begin.
Thank you so much for that introduction and welcome everyone. I am trying to find the slide deck now. I think it's this one. Let's see, I'm hoping. Nope. Sorry, Kristen.
This is my email.
I know. Let me stop sharing until I find and we've got play. Okay. So sorry for the delay. Good morning, everyone, and welcome to Basic Dermatology. We've already covered that you are eligible for CME for this presentation, so I do hope you take advantage of that. And going back, I have nothing to disclose. So for the presentation today, we're going to be discussing a little bit about topical medication basics that I think are really important information for you to be aware of, as well as how to choose a topical corticosteroid. And I've got a lot of dermatology cases that we'll be going through, and I've written down everything. So don't be concerned about taking notes. Additionally, I have a very large appendix, which is at the end of the slide deck. And that appendix has a lot of more information about appropriate use of certain potency corticosteroids for certain conditions, such as psoriasis, bug bites, things like that, just a guide for you. But we're not going to be able to have time to go into all those details during this presentation. So for the topical medication basics, I think all of us know that the efficacy of the medication that you're giving is really dependent upon its strength and concentration. But location where you're having the medication be used is also very important as well. So let me give you an example of that. Let's say we have a very mild dermatitis around the upper lip. 1% hydrocortisone ointment would be very effective for that very quickly. But if, say, that dermatitis was now on the palm of the hand where the skin is very, very thick, the stratum corneum, the outer layer, is one of the thickest areas on the palm and the sole. So 1% hydrocortisone would not be effective. It wouldn't be able to penetrate in sufficient concentration and potency to stop the inflammation on the palm. So you'd have to select a different product. Now, vehicles, I think, are really important. And no one ever gave me a talk on vehicles when I was a dermatology resident. And it was only when I was starting to see patients for allergic contact dermatitis as I was working on latex allergy that I began to realize how important vehicles are, not only in topical medications, but also in the over-the-counter products that we recommend for our patients. So I'm just going to spend a very short amount of time. I've got 2 slides where we talk a little bit more about vehicle formulations. So my favorite vehicle, especially for topical medications, is the ointment vehicle, which is petrolatum. And when I'm saying petrolatum with my patients, I'm pretty much telling them it's petrolatum in the jar. It's not ones, oftentimes you can get petrolatum in a tube. But what's happened now is many of the times with the petrolatum in the tube, they've actually added a whole bunch of other ingredients, and it's not just the plain petrolatum. So again, the reason why I like this is because petrolatum is not an allergen. It's not comedogenic. And more importantly, it doesn't sting on broken skin. The downside to petrolatum is the complaint I hear from my patients a lot, which is that it's very, very greasy. Now, the good news is when we're using this, oftentimes it's on broken skin, and that skin will really kind of suck in all the grease. And so I tell my patients that if they wait at least 15-20 minutes after applying the petrolatum, they really shouldn't have too much greasiness and too much concerns like getting dressed and clothing getting stained by the petrolatum. Now, creams, on the other hand, are very what we call cosmetically elegant, meaning they're not that greasy and they'll vanish when rubbed in. They're created mainly by starting out with oils and then you add some water. Now, unfortunately, anytime you add water to a product, you're running the risk of bacterial overgrowth. So the companies have to do something about that to extend the shelf life of the product. So they'll add preservatives. Now the preservatives, unfortunately, can be inherently irritating to normal skin, and they also can have an odor. So the companies then have to add fragrances to mask the odor, as well as other chemicals to kind of make them not so irritating. So at this point, you now have a product that's got a whole bunch of other chemicals in it. And preservatives and fragrances are very, very high on the list of chemicals that sensitize patients and make them allergic to the preservative and fragrance. Lotions, I think we're all familiar with. They're really not very moisturizing at all. And that's not surprising because they're mainly water. They have a little bit of oil added to them. And unfortunately, they oftentimes contain alcohol. So typically they'll be very stingy when people apply them on broken skin. Now, the next list of vehicles here we may not use as commonly. I really like oils with the topical medication when you have lesions on the scalp. They don't tend to sting and burn like the lotions and solutions do, and they don't leave a really greasy residue in the hair like a petrolatum-based ointment would. Gels I rarely use, and that's because paradoxically, many people get a stinging or itching sensation on normal skin when they use a gel. Gels have a really good role for acne preparations, and you'll notice that a lot of the topical prescription acne products are gel-based. They do contain alcohol often as well. I really like foams. I'm not sure if any of you have ever had the ability to prescribe those for your patient, because foams, unfortunately, are really very expensive. They're wonderful for the scalp. Patients love them. Very lightweight, not greasy. So like topical corticosteroid foam for psoriasis on the scalp, people love. Most of the time, as I said, they're not on formulary. Sprays, I really don't recommend. It's really hard to tell when you're spraying something how much you've put on and where it's actually gone. But there are spray sunscreens over the counter, spray foot products, and again, I typically don't recommend those. I like powders a lot, especially when you have a patient with intertrigo or some tinea. It's best on the most moist folds of the skin. When the skin is broken, though, if it's been really moist and it gets macerated, then the stratum corneum tears, you get fissuring. If you put powder directly in that, patients can have a problem if the powder tends to clump and become kind of grainy like sand. So I tend to not use the powders until the maceration's improved a little bit, but they're really good for maintenance for those types of conditions. So we have, sorry. Oh, this is interesting. My slide was a little bit out of order. So hopefully this won't continue, but the one thing I was going to say about the vehicles in choosing them is that you want to make sure that you have a vehicle that is ointment based, and you want to make sure that you tell the patients that the greasiness will go away pretty quickly. So when choosing a topical corticosteroid, there are two things that I wanted to make sure you were aware of them. One was group classification and one was potency classification. And I think you're probably all aware of the group, the potency classification. The group classification is very important when you're dealing with people that have an allergic contact dermatitis, and they're actually allergic to the corticosteroid. So it will actually help you to figure out what topical corticosteroid they can use that's safe for them. And there are 4 groups that are in the group classification, and then the potency classification has quite a few classes. And you've got the topical corticosteroid potency, which has very high potency. Class 2 to 3 is high potency, class 4 to 5 is mid potency, and 6 to 7 is low potency. So I wanted to just take a moment to talk a little bit about 1% hydrocortisone, which is a class 7 potency level, and that can be used on the face, groin, and the skin folds. And hydrocortisone used to be prescription only, the 1%. Prior to 1990, if I saw a patient coming in with a rash on their face, I would be giving them 1% hydrocortisone, and it worked great. And what's happening now is oftentimes patients know it's over the counter. They'll tell me that they don't want something as weak as that. They know it's not going to help. Or they may say, Dr. Huber, I've had this rash on my face. I applied some hydrocortisone. It didn't work. You have to give me something stronger. So I generally let them know that this medication, 1% hydrocortisone, is actually a really excellent product. It works very well. I used it for years before 1990 as first-line treatment. It just needs to be used in the way that I let them know, longer, generally it's longer duration. They oftentimes just try it for a day or two. So why do we not use the other classes on the skin, groin, and skin folds? And that's because they have a really, really high tendency to cause atrophy. And so if they cause atrophy of the skin, the very first sign is the skin will get more red. And the patient will think that they're not better. They'll say, my skin is still red. It may not be so itchy, but it's still really red. And so they'll keep applying the medication. So then the next stage you get is significant thinning of the dermis, and you can wind up creating skin that's going to bruise very easily with very little trauma. And then in the skin fold areas, especially with the atrophy, you'll start seeing stretch marks. And unfortunately, even something in the mid-potency range, which would be like a triamcinolone level product in the skin folds, that can cause stretch marks just within 1 or 2 weeks. So that is a significant problem. Okay. So now we're ready to do cases. And at this point, Kristen, I think I'm going to have you pull up my slide set because I realize I've pulled up an earlier version of my slides. And if
Okay,
you could share your
sure.
screen.
Re
And okay, and I can see the slide deck. Yay. So we went through the potency classifications. And if you can go to the next slide for me, keep going. There we go. So I do recommend that you make yourself familiar with 2 formulary medications of each potency class. And then we talked about, next slide. For chronic and recurrent conditions, the goal is to just use the least potent corticosteroid, obviously, and to use it as infrequently as possible. Now we do have products out that are the calcineurin inhibitors. That would be things like Protopic or Elidil. Those are just 2 brand names. And they don't cause atrophy of the skin. Unfortunately, those products do not work quickly. So if you have someone with an acute dermatitis and you really want to make them better faster, it's better to first start out with a topical corticosteroid of the appropriate strength before going on. And then for more corticosteroid information, please do check the appendix at the end of the slide deck. Next slide, Kristen. Okay, next slide. So I have a lot of cases, and I wanted to start with just a couple pictures of something that we see all the time in the clinic. And what I'd like to do is tell you what I'm seeing and what I think that's important in the skin findings that help me to make the correct diagnosis, but also help me to make sure that I'm treating it appropriately. So this is an older woman who comes in, it's January, and she's complaining of a little bit of discoloration of the lower legs. And what I'm seeing here is a little bit of, there's some ill-defined areas of what looks like dryness, but I would say it's slight scaling. And there's lines that we can see that are hypopigmented, kind of, they resemble cracks in a roadbed. Next slide. Here's another gentleman, it's winter also. He's complaining of a lot of ashy appearance of the skin. We can see there's an ill-defined area of the anterior lower leg and the right side of the ankle that looks like there's some small flakes. And we've got lots and lots of little crisscrossing, dry appearing lines. And if you will, these are little micro fissures and fissures of the skin. So we all kind of know what this is. Next slide. This is xerosis cutis, a fancy name for dry skin. I really appreciate it when my patients show me this early on because I now have a way to help them and catch something and nip it in the bud because this is the earliest sign that the skin is in trouble. We're having disruption of the skin barrier and we can progress pretty quickly to a much more severe type of eczema. So this is really common in the older age groups, very common on the lower legs and also on the back of the hands. Next slide. Environmental triggers are really common, especially for, I think your clinic is on the East Coast, so you can have those cold, dry winters and you have heated rooms with low humidity. Just those are sufficient triggers in older people to have the skin dry out and for them to start getting the xerosis and then moving on to eczema. Harsh soaps can play a role too. And the one thing I have found out with my patients is oftentimes when they see cracks in the skin, they become really worried about infection. And so oftentimes they're starting to use alcohol or even hydrogen peroxide on the skin because they're really wanting to kill any bacteria that might be there. And so those, of course, are counterproductive to restoring the skin barrier. So I've learned to kind of ask people, oh, what are you doing to try to make your skin better? Or, are there other things you're using on your skin? Like, do you use alcohol on your skin, for example? So I do recommend that. Next slide. So goals of treatment is to restore that barrier function, decrease water loss, and to prevent progression. Next slide. So for treatment, I also do make sure that they're not using a bath brush or a loofah. And it turns out that a loofah or a bath brush can develop significant bacterial colonization within a month of using it. So if patients insist on using this type of product, which I don't recommend, I do let them know that they need to change it every month. And certainly when they're getting broken skin, they shouldn't be abrading the skin. So soap substitutes. Oftentimes I tell people, unless you're out in the garden and this area of your skin is really getting dirty, you really don't need soap. Just water is fine. But for those who want to use a soap, I'll have them get a plain glycerin soap, which you can get over the counter in like health food stores and whatever. But you do have to be mindful that it doesn't have fragrance in it because that can cause allergies. Next slide. Moisturizing often, as we know, we've already talked about the petrolatum. For creams, I did mention that you can use the ceramides. Also, there are creams that have dimethicone, which makes them very lightweight and not greasy. So people will like that. Next slide. So once the microfissures of the skin are improved, you can go to products with lactic acid. Now, lactic acid can cause stinging or burning even in normal skin. So some patients really don't like this product. But for those who really are upset that they still will have their skin look a little dry once the moisturizer is sort of worn off, this product can be really helpful. It will exfoliate those little flaky areas, and it's also leaves a very smooth feel to the skin. I do remind the patients, though, that especially if it's wintertime, that, winter hasn't gone away. Their skin may have improved a lot with the treatment we're recommending, but they need to maintain it because oftentimes people will stop. They think their skin is fine and, they'll just stop and they'll be back in your clinic. The other comment I wanted to make, since I had an earlier slide on it in my original deck, was that for patients that are trying to avoid fragrance, the most allergenic preservatives, if they start to look for over-the-counter products that are marketed for babies or for sensitive skin, or they say hypoallergenic, they can be assured of having a product that may have fewer of the sensitizing preservatives in them or fewer fragrances. And typically the baby skin products, the companies really do due diligence in trying to make a product that's safer for the baby's tender skin. Next slide. So what happens if the patient didn't talk to us about their dry skin? A lot of times people don't bring it up because they don't think it's a big deal. So then we wind up with a patient who comes in like this. So now what I'm seeing is a very ill-defined area of rash, which is very typical of eczematous processes. What I mean by ill-defined is it's really hard to draw a line precisely around where the rash ends and where it begins. And that's different from other things like psoriasis, which is we will say is very well demarcated or well defined. I'm also seeing that we now have some erythema, unfortunately, and we have red fissures, red linear lines with really thick crusts. Next slide. I wanted to include this slide because this is the same condition as what we just showed you. But in this case, the patient had applied some moisturizers prior to coming into the clinic. And the grease of the moisturizers really accentuates the inflammation. And I wanted to bring up that point to you because I've had a lot of patients early on in practice when they started using the medication I gave them or started using the greasy moisturizer I recommended, they would call me up and say, "Oh my gosh, I'm so much worse. Everything is really red. Everything's looking worse. I think you're giving me a product that's making, me worse." So I would bring them in and look at them, and they were actually doing better. But the greasiness of the products will actually accentuate the appearance of the erythema in their skin. And that's what we're seeing here. We're seeing a really bright red, which we didn't see before. So I just wanted to make you aware of that. And I tell all my patients that the moisturizers can make their skin look more red. Next slide. So most important thing here is that the patient shouldn't be rubbing or scratching, because that's what's starting to happen due to the dryness of the skin will create sensation of itching. And then you start responding to that with rubbing and scratching, and then you get the eczema. Again, patients can be using other products such as the hydrogen peroxide or alcohol. I did want to put in a side note here about melaleuca oil, although it does have antibacterial properties and people do find it helpful for their eczematous skin conditions. It is highly allergenic, and I can't tell you the number of times I've seen people who have developed an allergy to the melaleuca oil after using it several months. I was called to the ED one day to see a gentleman who had a rash, just like the picture that I showed you on the ankle. And he was using the melaleuca oil. And then when I saw him in the ER, his entire lower leg was edematous, it was weeping, and he had severe acute contact dermatitis from the melaleuca oil. Next slide. So at this point, we do need to use a topical corticosteroid. Any of the three I have listed here are fine to use. I personally, for this patient that we saw with the rash on the ankle, I would use the fluocinolone ointment, which is your high potency corticosteroid. And the reason why is that it will work quickly. The patient will hopefully, get out of the itch scratch cycle that was starting to be developed. And so I would do that. I'd use it at least twice a day. I would tell him to be applying a moisturizer afterwards and rubbing that into all the areas of the skin surrounding that are normal. I make sure the patient only uses the medication first on the area of involved skin and just a small amount. I've had people that sometimes want to prevent new areas from coming, and they'll try to apply the medication all over the entire lower leg. So I really stress the importance of not doing that. As the patient gets better, then we can consider tapering the corticosteroid. So next slide. Talked a little bit about that. Next slide. So this gives you an example of tapering. Typically, I start the corticosteroids twice a day. If they're doing really well, then they could just use it at night and use their moisturizer in the morning for a couple of days. If they're still doing well, then they could use the steroid every other night for a week or two, and then just, but still using the moisturizer. And on the days that they're not using the topical corticosteroid, they would be moisturizing twice a day. I think that is really helpful. I've had a lot of patients where as soon as they're better, they abruptly stop the corticosteroid. And the problem is you've got an inflammatory cascade that started in the skin, and it takes a while for that to calm down. So I tell the patients, your skin is primed to just kind of break out. The rash is primed to just break out again pretty quickly. So we want to keep giving the moisturizer, putting the moisturizers on the skin, and we just want to taper off the topical corticosteroids slowly to avoid a flare. Obviously, if they're still needing the corticosteroid a lot, they need to see you again and be seen and evaluated. Next slide. Okay, so this poor person had started out with medication to use for a xerotic eczema, but unfortunately they ran out and they wound up being very stressed and they were scratching a lot. And this is what we really don't want to see coming into our clinic. A patient was complaining at this point of some discomfort and marked increased redness over the last few days. And then unfortunately, the skin was getting moist. So what I'm seeing at this point is a fairly sharply defined area of erythema. Significantly, there's honey crusting and there's oozing at the lower area. There's probably a few excoriations in there as well, but harder to tell. So now at this point, we have an eczema that has gotten infected. So If it's just this area of skin, you may be able to get by with using something like mupirocin, or you could use oral antibiotics. I think for myself, when I'm looking at this, there is a little bit more rash in one other spot. I would probably give an oral antibiotic, and I would use a class 1 corticosteroid, and that would be something like clobetasol. And I would be using that class 1 corticosteroid for at least a couple weeks and then tapering it or switching the patient to something more like a triamcinolone to continue to use as they get better. Any questions at all in this case?
Let's see, there are a few questions. Um,
Okay.
okay. When do side effects of steroids start for low, medium, high potency if a patient is using twice daily on a non-sensitive area like the leg, like after 2 weeks?
No. So for thicker areas of skin, it takes a lot longer to see atrophy. And certainly before we had other products like the calcineurin inhibitors, as a dermatologist, all we really had were the topical steroids. And we have people with atopic dermatitis where they have ongoing rashes. So I would be using triamcinolone. Patients could be using it for months. It's just they would be minimizing, maybe it's not every day. Sometimes it was every day, twice a day. Over time, I mean, we're talking many, many months, you would start to maybe see a little bit of skin thinning, but not like what you'd see with the class 1 corticosteroids and the class 2, 3. Um, so I'm having a hard time answering that question primarily because I know that in my atopic dermatitis patients where they were using something like a class 2 or class 3 topical corticosteroid almost every day, eventually they got skin thinning, but it took a while. The face and lips and skin folds, things like that, that's where it will happen really, really quickly. And that's why you're always in that class 7, hopefully, level of corticosteroid.
Okay. Next question is, do you have any recommendations on use of systematic steroids for any severe dermatitis, i.e. severe poison oak or psoriasis? And do you have any criteria for IM versus oral systematic steroids?
Ah, that's an interesting one. So I am covering that in one other case that we have. So I think I'm going to hold that question to
Okay.
that case.
I will hold
Okay.
that one. And then let me just make sure. When you see a secondary infection, would you wait a bit for the antibiotic to work before starting topical steroids?
No, I would do them both together. We need to get that inflammation down.
All right. We'll hold off on the rest of the questions until we get to the next case.
Okay. So next slide. This is just another picture of impetigo. I think it's really good to see the pictures. When you start seeing wetness, then you know there's a secondary infection. And again, you can see this is kind of more well-defined areas of scabbing. Next slide. Okay, this is much more extensive. So unclear if this, I didn't see this patient personally. It looks to me like they may be an atopic dermatitis patient. They've got numerous areas of epithelial disruption, which is, fissuring, crusting. They've got fairly extensive erythema. So, in this type of patient, especially if they're miserable, they can't sleep, I would think about systemic corticosteroids. I tended to always like doing the oral corticosteroids. I had a pretty compliant patients in terms of follow-up. And partly I've liked that because I can control the taper. And I can control how much how much prednisone or something that they're being exposed to. With the IM, you have a given amount, it's going to wear off. You really can't be as flexible in dosing. So that's just a personal preference of mine. You can talk to somebody else who would give IM like 40 milligrams all the time. But for me, I really tended to do the oral because I tried to minimize the duration and amount of oral steroid they were on. So for this patient, I would be giving prednisone. Let's say it's, a total body rash, essentially 40 milligrams in the morning with food. I would do that for a week. And typically 1 week of 40 is really, really good. It will calm things down quite a bit. And then where I made a lot of changes would be in my length of taper. And that's just something over time that, and following up my patients, that I kind of um, sort of figured out what types of tapers I liked. Typically, when someone's this severe, I think if you went to like 30 for one day, 20 for one day, and 10 for one day, that's not sufficient. So I would most of the time be going 30 for a couple of days. In this particular patient, probably 30 for 3 or maybe even 4 days, 20 for maybe 3 days. So now I'm close to 2 weeks of the oral corticosteroid. And then at that point, maybe 10 for 1 or 2 days, and I'm done. And that could hold them. I will make sure they have a topical corticosteroid to use, or if we're using Elidel or Protopic, that they have that available as well. So I never really had like a tried and true plan, except with the fact that I never had to use more than the 40 milligrams of prednisone when treating severe dermatitis. Some of my colleagues would go up to 60. I mean, rarely go up to 80. I never felt that that was important, and I did really well with just the 40. But I always made sure I gave it for a week and that I didn't do a taper until I'd given it for a week. And hopefully that helped with some of the questions. And next slide. So what happens if you have a patient who can't afford clobetasol, or they only have 1% hydrocortisone, or maybe the 0.1% triamcinolone? You can increase the potency of these low to mid potency topical steroids, and you do that through occlusion. Most important thing is to not occlude an active infection. So this is the one case where you'd want to get control of the infection, and then if you're going to occlude the skin, wait till that's abated, the infection's gone. Occlusion can be done with plastic, essentially, the saran wrap, plastic baggies for feet, vinyl gloves for hands. Typically, it's left, so you apply the topical corticosteroid, then you occlude it. That wrap material is left on for 6 to 8 hours. I was told to never do occlusion for more than 7 days because you're really bumping up the potency of the product. You do get sweating underneath it. I think people were worried that maybe you might start to get an infection if things are wet and moist. If people are sweating in the wrap. And then the other thing is you are maybe increasing the risk of some atrophy occurring if you go longer than that period of time. Next slide. And that's a damp wrap. So we used this a lot for people that kind of had total body erythema. This was kind of back in the day when, we don't have access to other treatments for that. It's called an erythroderma. We also used it sometimes for some patients with some psoriasis, but it was mainly erythroderma. But you would put the topical steroid on, and then you'd put on a damp cloth. And the reason for that is the dampness decreases the barrier efficacy of the stratum corneum so that the medication can penetrate in. Next slide. Okay, this is a skin finding that I think is really important that you be aware of because it gives you so many clues about what's going on with the patient. So what I'm seeing here are really marked skin lines, kind of railroad tracking, you could call it, but and thickened skin. So next slide. This is another picture, same thing. So when we're looking at this, some people will say, oh, it looks like alligator skin or elephant skin, but you're seeing accentuated skin lines because the skin is thickened. As you look up along the wrist area, you can see that there are tiny little papules up there along the wrist area as well, and that's areas of even more thickened skin. And I can see that there is a few excoriations. Next slide. This is just yet another example, not quite as severe. We don't have the erythema this time, but we do have a fairly widespread area with thickened skin lines. And this was oftentimes how my atopic dermatitis patients that were in pretty good control would look. And so that's a very common appearance. And next slide. Okay, this is an individual who has been complaining about a lot of itching, and you can see really, really thickened skin, erythema, and a small excoriation. So what is this? Next slide. This is lichenification. So this is a really important thing for you to recognize because it means the patient is rubbing the skin. And they're actually rubbing the skin more than scratching it, because otherwise we'd see lots and lots of linear bleeding excoriations from scratching. But this means it's also chronic. So even if the patient doesn't want to tell you, and most of the time patients don't really want to admit that they're rubbing a lot, um, you know that they are when you see this finding, and you also know it's been going on for a long time, that this isn't just an acute rash that started. This has been present for a long, long time. Now, unfortunately, when skin has been rubbed a lot, it will become more itchy. And I would share with my patients that they did a wonderful study where they took normal people with normal skin on the back of their hands. They drew a little round circle on the area of the back of the hand, and they asked the people in the study to very lightly touch their skin for about 5 minutes at a time in that area 3 times a day. And at the end of 3 weeks, that area of skin had become red, elevated, and itchy. So it's just kind of pointing out what will happen when you wind up touching the skin a lot. Next slide. So treatment, I will tell my patients when I see this finding that there is nothing that I can give them that will help them unless they stop touching the skin. I will tell them also it's going to take a while for the treatment to work. And hopefully with the treatment, the itching will start to abate. Depending on the skin area, it may take a couple weeks for the itching to improve significantly. But if it's on the face, sometimes the itching can improve in just 4 to 7 days, in less than a week if they stop touching it. Typically, you're going to need a high potency to very high potency class steroid. But of course, you can't use that on the face or the skin folds, as we talked about. And so if we look for that last patient, if you go back a slide or two for me to that last patient, yes. So this patient in particular, I would be using clobetasol ointment. I'd use it twice a day. I'd have them, not be touching the area. I would expect that at the end of 2 weeks, I would generally have them get back to me at 2 weeks to let me know how they were doing. I would expect them to be better. I would not expect them to be well or to have this skin look clinically fine. And I would be using that product probably for another 2 weeks. At that point, hopefully they're doing really well, and I could have them start a slow taper like what we talked about. But if we stop this too quickly, it's just all going to be back, and we'll lose any of the progress we made. Also, sometimes people would benefit from oral antihistamines to help them as well. Next slide. Keep going to where we were before. Yep. Now, sometimes you have to be creative. So I did have a lady who was a stewardess, and she was very stressed in her job, and she wound up rubbing her forearms whenever she was very stressed. So she would wear long sleeves, but still be rubbing the skin through the sleeves. And when I first saw her, we tried everything because her forearms were a mess. She was very embarrassed when there was warmer weather. She was still wearing her long sleeved uniforms, and people would look at her funny. Why was she doing that? And I really wasn't able to improve her with just topical corticosteroids, with the antihistamines we were trying. And so we ultimately had to Una boot her arms, and that worked great. Within just a few weeks, things had improved incredibly to the point where she no longer felt the urge to be touching her arms. Things were looking wonderful. So sometimes you have to be a little creative and help the patient with occluding the areas so that even if they try to touch the skin, they can't. Additionally, there are some products where you have a topical steroid that's in a tape. It looks like Scotch tape. Oftentimes it's a topical steroid that's a high potent or very high potent one. And that can be very helpful if you've got some lichenified, a small area of lichenified skin that the patient just is worrying all the time. And so you can, Cordran tape is one of the brand names for it. So I would have the patient cut a piece of tape that has this medicine in it. They would put the tape on, leave it on for 12 hours, then change it. And we would get some really good improvement. The other thing that was nice about it is that if the patient was trying to rub through the tape, it was harder to irritate the skin because of the tape. So that's something to be aware of as well. Some people will get really lichenified papules that are just really, really thick and big. Sometimes some intralesional steroid could work just for that particular spot. Okay, next slide. All right, so this is allergic contact dermatitis, the eyelid skin. The eyelids are such thin area of skin that they will tend to react first to exposure to an airborne contact. Types of airborne contacts can be various chemicals and household products, but I had a patient who was camping and they put in logs in the fire. The patient happened to be allergic to poison oak and poison ivy, and that was on the logs. And so it became aerosolized in the smoke, and the patient wound up having an appearance much like this patient did. So how do I know this is acute? Well, obviously there's tons of edema. You're going to get the history from the patient, but there's also some signs too that we've got an allergic contact going on, because there's some tiny little shiny vesicles that are just fluid-filled vesicles of the skin that we see with acute contact dermatitis. For this patient, I would be giving them oral prednisone. I would be giving them the 40 milligrams as we discussed. And I would be doing a slow taper. So 40 for a week, then 30 for probably 3 days, 20 for about 3 days, 10 for 1 or 2 days, and hopefully that would take care of it. Now, it turns out that most of the 25% of the population will have an eyelid dermatitis sometime in their life, which is pretty common. And oftentimes it's just a one-off, but sometimes it can be recurrent. And I had a patient who presented just like this individual. And at one point in time, I treated her. She was fine for a year. She then presented with another episode just like this. She was fine for another 6 months. And at that point, it was her third episode, and had been racking our brains, what is going on? I wound up patch testing her. So if you have people with recurrent episodes and you can't determine anything, patch testing can be helpful. In my patient's case, it turned out that she was allergic to a chemical that could be found in a lot of products. And I was going through those with her. We couldn't find any relevancy there, but then it turned out it was in ant spray. And she was like, oh my goodness, periodically I use the ant spray. And she hadn't thought of talking to me about it when we were talking about products she was using, because she didn't really think that it was getting on her skin in any way. She's spraying the ants, she's not spraying herself. So just wanted to bring that case up. I would also, for this person in particular, probably give them some oral antihistamines as well. Next slide. Another example of an allergic contact dermatitis. Again, we see edema of the upper and lower eyelids and maybe a few little papules on the lower eyelid. This patient, I would also give oral corticosteroids to. Next slide. Okay, most common causes is the allergic contact dermatitis. You do have other causes. Irritant contact dermatitis typically doesn't cause so much edema and swelling and itching. It tends to cause more burning and irritation. Do be mindful that patients can be allergic to topical corticosteroids like we talked about. And specifically, if people are allergic to topical corticosteroids, oftentimes they're allergic to hydrocortisone. So keep that in mind because it's used on the face a lot. Next slide. Lots and lots of reasons for allergic contact dermatitis. So you really kind of have to be a detective with the patient when trying to sort things out. And certainly if it's recurrent, getting a dermatologist involved. Next slide. So this is an example of a little dermatitis on the eyelid. At this point, I'm not seeing lots of edema. I'm not seeing any vesicles, and I'm also not seeing lichenification. So it probably hasn't been there that long. Differential diagnosis for this, it could be an irritant dermatitis. It could be, so I try to find out how much itching there is, had it ever been swollen, because that would make me think a little bit more about allergic contact. But we could see allergic contact looking like this just from nail polish, for example, or from the patient who's metal allergic. If they're handling a lot of metal objects, it's really easy for sweat to pull some of the metal ions onto the skin, which you can then transfer other places when you touch your face. And eyelid skin is really the most sensitive skin of the entire face. It's really easy for it to erupt in response to an allergen. Could this also be a small amount of psoriasis? It could. If patient had a lot of psoriasis elsewhere, this could definitely be some psoriasis. For this, I'd use 1% hydrocortisone ointment, and a very, very tiny amount, barely visible amount. I stress that with my patient, and you only apply it to this area twice a day. Next slide. Okay, so this case, the main thing I want you to recognize with this case is that we don't have a ton of edema like we saw before in the couple cases. But what we do have is lichenification and some change in color. I think there's a little bit of hyperpigmentation and some scaling. So what does this mean to me? What this means to me is that this patient is rubbing a lot and that this has been going on for a while. Most important thing to realize is that the triggering factor for this may no longer be at play. So I don't know what created the dermatitis. It could have been something from a cosmetic, could have been airborne, but I do know that a significant, that rubbing has a significant role in maintaining the appearance of the skin and the skin findings we're seeing. And that if the patient does not stop rubbing, there's no way that they're going to get better. And I have had a lot of patients that got referred to me for evaluation of allergic contact dermatitis who've been like this for a year with no benefit, despite seeing their dermatologists, etc. And all that I wound up doing for them while I was patch testing, because patch testing, I see the patient over a week, is I would tell them, I only want you to be using Vaseline, and I don't want you to be touching the eyelid. And if you feel you must be using if you must touch the eyelid, I just want you to put Vaseline on your finger and very lightly rub the Vaseline in. Many, many times the patient was significantly better by the time the patch testing was over. Patch testing showed no contact allergies, and we really just had lichenification from the rubbing. So I just want to make you aware of that. Now, certainly you could use 1% hydrocortisone in this area, especially if they're not allergic to it. But again, it's that not touching the skin. Next slide. Some lichenification as well. I want you to recognize the thickened skin folds, and it's hyperpigmented. You'll tend to see the hyperpigmentation fairly soon in people that have darker skin tones. Next slide. And one more patient where we just see a little bit of some hyperpigmentation. And again, we have accentuated skin lines. So we know that we have to address the touching that the patient's doing. And it can even be just dabbing their eyelids with this Kleenex. I had one lady who was doing that, and that was sufficient to cause problems. Next slide. So there's lots of do not do's when you're dealing with patients with eyelid dermatitis. And we talk about, stopping the eyelid, cosmetics, not having soap or shampoo running down onto their eyelids, not using hairsprays or other aerosol household cleaning agents. Next slide. Avoiding artificial nails, use of nail polish. And it's really important that people not try to peel the flakes off their skin. And that's the one reason why I like the Vaseline in the jar to use on the skin. It will kind of keep those flakes down. A lot of people find them irritating and try to peel them before they're ready to fall off. And then as they improve, the skin will be even more flaky until it's not. Next slide. So these are the cans that they can do, and I've kind of covered this fairly well, so I think we'll go on. Seborrheic dermatitis, very common. So I just wanted to point out where the skin findings are, which is scaling in the eyebrows. Next slide. Hairline, next slide. Nasolabial folds, next slide. Next slide. Right, so we saw the common areas. You can see it as well with the greasy scales and erythema on the mid-chest and also in the groin. Next slide. I really love the medicated shampoos, and my tip for you on this one is to have the patients pick 3 over-the-counter shampoos with different ingredients that they dislike the least and have them rotated. So every week they can use a different product. And I really think switching up the active ingredients is really helpful for this condition. And then as they improve, I do recommend patients that have this condition, because it is chronic, it's not curable. Stress can make it worse. I just have them use the medicated shampoos on an ongoing basis about 2 times a week to try to keep this under control. Next slide. If there's erythema or scaling at the hairline, you can use these low potency corticosteroids that are for the face, the hydrocortisone and the desonide, or something like the fluocinolone and the betamethasone for the scalp. And next slide.
Just want to give you the 5-minute warning.
Thank you. There certainly are other medications that have no tendency for skin atrophy. So that could be your clotrimazole or your Elidil type product. Again, those work a little more slowly. So sometimes you can use them in combination with a corticosteroid and then stop using the corticosteroid after a week or two and just continue with these products. That can help. Next slide. Blepharitis. I love this treatment with 1 or 2 drops of baby shampoo and a capful of water and using a little Q-tip with the eyes closed along the eyelid lash rim. That can be really helpful. Next slide. And I did want to make you aware of another type of clinical appearance of seborrheic dermatitis. It's being reported now more often. It's more common in people with darker skin tones. And you'll get these little coalescing rings in the typical areas of seborrheic dermatitis. Be aware, there is a differential for this. So now you're starting to see a more well-defined rash, well-demarcated, and you have to think about things like tinea corporis, tinea versicolor, more importantly, lupus, secondary syphilis. So here's an example, next slide, of what it looks like. And you can see this looks very different from what we think of as seborrheic dermatitis. You've got these little arcuate forms that are very well defined. You can tell where they stop and start, and they almost look like you have a raised border. Next slide. So anytime you're seeing something like that, you do have to think about tinea in your differential and also lupus. And you can see here the patient has had a biopsy done by the dermatologist because they're trying to rule out other possibilities. But this did turn out to be a seborrheic dermatitis. Next slide. Tinea versicolor. So I know we're running out of time, but I did want to hit a few highlights on tinea versicolor. So it's versicolor because it can look lots of different ways. What I'm seeing here are very well-defined small papules that are coalescing into a plaque. It also looks a little bit drier than the rest of the skin, like there's a fine scale. Next slide. In this slide, the scale is a lot more prominent. So when I see a patient where I'm thinking of tinea versicolor, I always, and I can't tell if there's any flakiness, I'll always try to scrape the skin a little bit. And if I see those fine flakes, then I know I'm on the kind of right track, that it's probably going to be tinea versicolor. Next slide. Big point about this is that the melanocytes are affected by this overgrowth of the fungi on the skin, and that prevents the melanocytes from making normal pigment. So most of the time this will happen in young people, humid climates, working out in the gym, and they'll wind up saying, hey, I got a tan, out on the beach, and I have this horrible rash, and people think I'm contagious. So sunlight is going to accentuate the appearance of the lesion because the abnormal skin doesn't make normal pigment in response to the sun. Next slide. Very common in the areas we're seeing, chest and back. It's asymptomatic. Next slide. And this is a wonderful picture. Sometimes I can't tell what is the normal skin and what's the skin that is affected. So again, flaking, abrading the skin just a tiny bit will show you the areas that are scaly. And then you do want to collect that scale. Next slide. And another slide. Those are the 3 different colors that we've now seen. Next slide. We want to do a KOH. So hopefully all of you are familiar with KOHs, and I have a wonderful slide next that shows you what it should look like. And it's that spaghetti and meatball appearance. And KOHs are really difficult. I didn't feel comfortable and confident until I had done them for about 3 years. And you'll see lots and lots of little cell lines that are disrupting it. And then the fungi are going to be those birefringent, kind of greeny, thicker lines that are the spaghetti. Next slide. I love topical treatment. There is oral treatment, and you'll see that in the slide deck, but topical treatment works great if it's used this way. The other reason I like topical treatment is that it prevents recurrences. Oral treatment is not going to prevent a recurrence, and this is very, very recurrent. So you can wind up looking through these slides at your leisure. I do want to advance just a couple more. Next slide. Next slide. Differential diagnosis, just making you aware that there are other things for you to think about, especially if you don't have a positive KOH. So this can give you some other possibilities. Next slide. It's really important to encourage the patient to use that selenium sulfide 2.5% shampoo once a week on an ongoing basis for prevention. Next slide. Tinea corporis. So what I want you to see in this slide is the fact that we've got a raised border. It's a very well-defined rash. Anytime you see something with a raised border that looks like this, you need to do a KOH. Oftentimes tinea corporis is just one spot, but it can be many. And I had a colleague who got very fooled because she saw a small child, well, a young child that had about 15 spots. And she decided it was another type of dermatitis, like a nummular dermatitis, which can be coin-shaped looking. And she didn't do a KOH. And it turned out it was tinea corporis. So please don't, always scrape. Highlight with tinea corporis is it starts out small and the patient will say it's expanding and you get skin clearing in the center. And I think this slide depicts that very well. Next slide. Where do you do the scraping from? You do it from the border, the rim that's raised. That's where you're going to find the hyphae. And you can see that the center has many cleared areas of skin. Now, what else could this be? Well, psoriasis typically won't have skin clearing in the center. It can be a well-marginated plaque, but it's not going to have this raised border. So nummular dermatitis is generally got lots of little fissures and things that we saw in the earlier things of dermatitis. So the big rule out for this is, tinea. Next slide. One more slide. And one more. Yeah, this is also tinea corporis. It's a really moist area. So my last, one of the last cases I have here is intertrigo, and it talks about how to really control the environment in this area. If you don't control the sweating in this area and help the patient with some ideas on how to keep the skin dry, you're going to keep having issues with this being recurrent. So thank you very much. I'm sorry we had trouble with the slide set. I apologize for that. And I appreciate your attention and hopefully it was helpful.
Thanks so much, Dr. Huber. We have a couple questions.
Yep,
Fortunately, I have to run soon, so we can only do a couple today.
sure.
Let me just go into here. We answered that one earlier. Can Benadryl, either oral or topical, help with itching?
I don't like the topical just because I'm an allergic contact dermatitis worrier because I've seen so many people with products. So I would use it orally. That can be very helpful. But I really try to minimize the topical things that I put on the patient's skin just because of the other vehicles that are in them.
All right. Just gonna take a quick thing. Some of them are really long and be really good e-consults. So if you have any questions later, you can submit an e-consult. Do you recommend testing for any vitamin deficiencies for general skin issues like cracking, fissuring, eczema? I read that
I
vitamin.
never did.
Okay. All right. All right. Well, okay, last one. How does nail polish irritate eyelid? Like touching around the eye with nail is enough?
Yeah, it's very interesting. I think it's oftentimes fairly soon after the nail polish has been applied, so it might not be completely dry. Um, but I think also, sometimes we think the chemicals are staying where they should be, like I don't want to say it, they won't get pulled off the skin, but I think you can get small amounts that could just get pulled off the skin from the nail polish, even when it is dry. And the eyelid skin's just so sensitive if you're allergic to the chemicals that are causing it.
Dr. Huber,
Okay,
thank you so much, and thank
thank
you
you
all
so
for
much.
joining us today. This was great.
Yeah,
See you
thank you so
soon.
much, everyone. Bye.